Welcome to The Explainer. Today, we are tackling a question that is, deeply personal and honestly pretty stressful for a lot of people. What do you do when you're pregnant or breastfeeding and you need to take medicine?
This is a situation millions of people face. It pits their own health needs squarely against the safety of their developing child. And for so many, it can feel like just an impossible choice, right?
It is such a delicate balance. And the stakes? Well, they couldn't be higher. So how do patients and their doctors actually navigate all this? How are these critical decisions really made?
All right, let's just dive right in. First, we're going to unpack why this is such a tricky issue to begin with. Then we'll get into the science for both pregnancy and breastfeeding, because they're different. And finally, we'll give you a kind of toolkit, a framework for understanding how these decisions get made.
Okay, first section, medicine's toughest question. So why is this whole thing so incredibly complicated?
So the reality is, just avoiding all medicine? It's not always possible. And sometimes it's not even safe. Think about it. You've got pre-existing conditions like asthma or depression that need managing. You've got pregnancy-specific stuff like really bad nausea or high blood pressure. And then, of course, you can just get sick with an infection. And here's the kicker. Leaving the mother's illness untreated can be a risk to the baby too. So it's not a simple choice.
And this right here gets to the absolute heart of the problem. For really clear ethical and legal reasons, pregnant people are almost always left out of clinical drug trials. What does that mean? It means there's this massive information gap. It forces doctors and patients to navigate these decisions without a whole lot of direct human data to go on.
Of course, the number one fear, the big one, is the risk of a drug being teratogenic. That's the scientific word for a substance that can mess with normal development and, potentially cause birth defects. And that word, it's grounded in a really tough history. The tragedy of thalidomide back in the 50s and 60s, it was just a devastating wake-up call for everyone. It proved, without a doubt, that some medicines could cause terrible harm. But it also taught us something absolutely crucial. The risk isn't the same for every drug. It depends entirely on the specific medicine, the dose, and, this is so important, the timing of when it's taken during development.
Okay, so let's start to piece this all together. First up, the pregnancy puzzle. To really get a handle on the risk of any medicine, you first have to appreciate the incredible, almost unbelievable ways the body itself changes during pregnancy. Now, this is where things get really fascinating and, a bit scientific. Pregnancy completely changes how the body handles medicine. Just look at this table. Everything from how a drug is absorbed to how it's flushed out, it's all different. So, for example, your liver enzymes or your blood flow can change so much that a normal dose of a drug might get cleared way too fast to even work, or it could hang around in your system for way too long. The normal rules, they just go out the window.
And that brings us right back to timing. Because the risk is not a constant thing. It's always changing. You can see here how the level of danger shifts. Super early on, it's often an all-or-nothing kind of thing. But then you hit that middle period, from about week 3 to week 8, and that is the absolute peak sensitivity for major organ development. Later on, the risks change again, becoming more about function or growth. It just goes to show, when you take a medicine is every bit as important as what you take.
But then, after the baby is born, the whole puzzle just resets. Everything changes. Now we're looking at the breastfeeding equation, and believe me, it involves a totally different set of calculations.
And listen, this is probably the single most important takeaway here. A drug that's safe during pregnancy is not automatically safe for breastfeeding. And why is that? It's because the core concern is different. See, during pregnancy, the worry is about the drug affecting how the fetus develops. But with breastfeeding, you're focused on just one thing: how much of that drug is actually getting to the baby through the milk. It's a whole new ballgame.
So what makes a drug more likely to get into breast milk in the first place? Well, you can kind of think of it like this. Certain molecules are better at sneaking past the bouncer, if you will. The smaller they are, the more they dissolve in fat, the easier it is for them to slip right into the milk. And those are the exact properties that experts are looking for when they're figuring out the risk.
Okay, so how do they actually put a number on that risk? Well, they use a really important metric called the relative infant dose, or RID for short. It's basically a calculation that gives an estimate of what percentage of the mom's dose Adjust it for weight, the baby is actually getting through the milk. So what's the magic number we're looking for? Well, while it's not some kind of absolute guarantee, an RID of less than 10%, that's the general safety threshold. For most medicines, if it falls below that number, it's considered pretty acceptable. And that gives doctors and patients a real piece of data to anchor their whole conversation.
Okay, so with all this complexity floating around, how do you and your doctor actually make a choice? Let's open up the decision-making toolkit and walk through the principles for having a really informed conversation.
Really, it all boils down to this one core calculation. Every single decision hinges on this, weighing the known health benefits for the mother's health against the potential risks to the child. It's a balancing act, and for a medicine to be used, that benefit has to clearly, and I mean clearly, outweigh any potential risk.
And that logic leads to a really clear set of guiding principles. Number 1, use medicine only when it's absolutely essential. 2, when you do need something, go for the drugs that have been around a while, the ones with established safety records. Try to avoid the brand new stuff. 3, always use the lowest dose that works, for the shortest amount of time you can. And maybe most importantly, this has to be a partnership. The patient has to be fully informed and be a real part of that final decision.
And you should know, these decisions aren't just a guess. Not at all. Doctors rely on dedicated, evidence-based resources. You've got things like LactMed from the NIH over in the US, or BUMPS in the UK. These are massive databases that pull together all the available human reports and studies on specific drugs. So the final call is always based on the absolute best data we have.
Because at the end of the day, there's just no one-size-fits-all answer here. The goal isn't to find some generic rule that applies to everyone. Nope. The goal is to do a totally individualized risk-benefit analysis together in partnership with your healthcare provider to find the right solution for you and your family.
And that leaves us with a big, final, forward-looking question. Given that huge research gap we talked about right at the beginning, how can we, as a society, ethically improve the way we do research and collect data in this supercritical area of medicine? You know, how can we provide better, clearer answers for the next generation of parents?